Okay. Hello, everybody. I just came from Lab 1 to Lab 4, and now I just met our wonderful team here that is going to perform this case. We have Ricardo Costa in the left. Say hello, Ricardo.
Hello. Hello.
So you know, Louis Nakayama beside him, Rodolfo Staico,
Hello, everyone.
and also our fellow here, Pedro Teixeira is from Rio de Janeiro, Niterói. So we have a very interesting case just to show you. That's our routine. It's important because you are going to see the routine and Dante from ACS patients. And we have the slides, and Ricardo is going to present what happened for this patient and during his course in the last month. I would say in this month, since June 2nd.
Okay. Thank
Ricardo,
you,
please.
Fausto. It's great to be here again. I think we have a very interesting case. This is a 65-year-old gentleman. As clinical presentation, he has anterior STEMI, which underwent thrombolysis on June the 2nd, so almost 20 days ago.
So that's important. Let's just to fix, to memorize everything. So 65 years old man, acute MI 20 days ago,
20 days ago.
anterior MI, and that was treated with lytics.
With lytics.
Okay.
And from that event until today, he's asymptomatic.
Okay. So in some other hospital,
He was in
and
some
then
other hospital.
he came here just to have a cardiac care.
Exactly.
Okay, go ahead, please.
So as risk factors for coronary disease, he has hypertension, dyslipidemia. As his medication, he's under dual antiplatelet therapy plus enalapril, beta blockers, dapagliflozin, and simvastatin. His labs, he has a preserved renal function, and he also did a transthoracic echocardiogram, which showed an EF of 34% with apical and anteromedial akinesia.
So he has low ejection fraction.
Low ejection fraction, 34.
Do you know the delay of the symptoms and to be treated?
We did not have this information.
Okay.
Yeah. But by the EKG, it appears that did not succeed because he has Q waves in anterior leads, as you can see, V2, V3, V4. And here is the angiogram that he performed a couple of days ago. And we can see his RCA is a dominant vessel with what appears to be a moderate lesion in this view. It's a diffuse disease in the mid portion of this RCA, some mild disease in the proximal segment. Here in the cranial view, it looks a little bit worse, I would say, but also, in the range, maybe close to 60 to 70%, no more than 70.
So no culprit lesion with 70% lesion.
About 7%.
Okay.
No culprit lesion in the
So
RCA.
let's go to the left system.
In the left system, we can see here in the RAO view, it calls the attention that his left main looks like a little bit, the diameter is a bit less than what you would expect for if you compare the diameter of the proximal LAD and the circumflex, but no significant disease observed. We do see some mild disease in the proximal LAD. And here in the cranial view, this is mild disease, some angulation there at the level of the septal.
So
And also
what is
some-
the percentage of lesion would you classify this?
Here in this
patient?
view, maybe 30%.
30%.
30%.
In the LAD or in left main?
In both. In
In both.
the distal left main and also at the proximal LAD.
And that could be the culprit lesion for the acute.
By the EKG,
yeah.
it looks like to be the culprit lesion, but we don't see any major signs here of a significant stenosis. We also have some disease in the mid to distal portion. I would say maybe around 50 to 60% as well. Here in the spider view, I think the appearance is mostly the same. We don't see a significant stenosis, a significant lesion in the proximal LAD. And finally, in the LV gram, we do see some, I'd say, important hypokinesia in the anterior wall. I don't think it's totally akinesia. I do see some movement there. And calls attention to the hyperkinetic inferior wall and also in the upper wall that we can see. I think it's more by what we see here. It's more than 34% disease EF. but of course it's compromised the anterior wall. It's very clear.
So just confirm that the LAD is the culprit vessel.
Yes, no doubt.
Okay.
By the EKG and the LV-gram, yes.
Okay.
Continuing here, so Fausto, I don't know if you wanted to discuss here.
Oh,
or
yes,
we should-
yes.
yeah.
I need you to stop. I'm going to ask you, Rodolfo, at this time, you're invasive cardiology. You're here doing this anatomic, I would say. You just identified everything. You finished this examination. Would you go and do a procedure in a patient like this? You stop, or you stop and think and do it? You know, many doctors do ad hoc procedures, even in the States.
Yeah.
So-
I stop, and it's necessary to see if right coronary artery causes ischemia,
Ischemia.
and the left coronary, the the left main lesion in angiography is about 30%.
30%.
Maybe
Would you do a further investigation with it, with IVOS or even FFR?
functional
Functional evaluation.
evaluation
Yeah.
is better.
Let me ask you, Louis. Louis, do you agree with Rodolfo? You can disagree between us because we discuss those cases every day, every morning here. Because as we are a referring hospital, many patients treated outside come to here to have a cath, an invasive procedure. So they have lytics outside and they come here because there is a long line of patients waiting for a diagnosed cath. São Paulo is a city with about, in São Paulo area, more than 20 million people live here. Can you imagine how many acute MI you have every day in the city?
Yes.
Okay.
Yes. Fausto, first of all, it's the culprit lesion, of course, is the LAD. I don't know how much word you think about this left main, because if you go with the Finet, you know there's a how can I say a smaller diameter from the left main comparing to the proximal LAD and the circle. So I think when you got to do the angio, you have to be worried because there's a lot of prognosis when you do have a left main. Or how severe or moderate lesions on the left main. We don't know how much it will be.
Okay.
So that's would be the main concern here. So imagine perhaps it will be a little bit more, but I will have to agree with Rodolfo said because we have physiologics, although we can concern about the LV experiment when you do physiological.
So Ricardo, they asked for a physiological study first. Maybe you can have both here. So it's very important. I learned here doing this several years that we need to avoid unnecessary procedures. There is nothing that's worse than to place a stent in a patient that doesn't need it. Do you agree with this?
I fully agree, Fausto, and I think it's a very important case because this is acute case. This is not a chronic disease. This is acute case. And when we deal with these patients, we always want to know what's the culprit lesion. And I think that in the past, we'll just go ahead and treat the culprit lesion, regardless if it was significant stenosis or is a ruptured plaque, or if it's not. Nowadays, I think this paradigm has been challenged. And here we have a case that it's clear the culprit lesion is a proximal LAD, because the EKG, the LV compromise, but it's a very mild disease. So what to do is imaging that we can identify and maybe has some, let's say, objective measurements that we can take and information to say, okay, I have to treat that with a PCI, or to do physiology. Physiology is not indicated if you are in the first week to identify the culprit lesion or to assess the significance of a
So, but we are in 3 weeks now.
But it's 3 weeks now, so that could be applied as well.
Okay, good. So what have you done so far, Ricardo?
So what we have considered to do is first to have a physiological assessment, not only for this potential culprit lesion, but we also have some doubts about the significance of the lesion in the RCA. And there's a new system that we are now using in a routine in this hospital that allows us to do physiology by angiography. We don't need a wire to go there.
Okay, we live only with the angiography.
Only with angiography.
Can you show us this new system, please?
So this system is called the MiFR.
MiFR.
MiFR. So there's a concept very well known. The QFR has been already many studies, well validated with the invasive FFR. And now I think that's some advancement with the MiFR, with this software that is very, very accurate to the contour, to detection the contour of the vessel, and to give you the assessment of each lesion, each segment within the coronary vessel. You can have a bifurcation, you can have a side branch.
Okay. Do you have pictures of these in the slides?
Yeah, can I have a slides, please?
Okay. Maybe you can show everybody.
So here, this is how it was done in the RCA. So maybe Lou, you want to comment here?
Yes, Fausto. So we do the angel, and you just have to use a computer, a normal computer, with the software, and you can do almost like a KCA, and you can do the measurement, and you can how can I say? You can just do a pullback.
So this is performed in the right.
Yes.
This is performed first in the RCA, and see also there's a function that is being constructed there based on the contour of the vessel. So when you see the deflect of the curve, that's exactly where the stenosis are, and you see the color code. You see the blue in the right extreme left. That's no significance in terms of the ischemia. But as you move towards the stenosis, then you see the color becomes green and then yellow and then red.
How this is measuring, just to understand. I mean, from the colors. Why? How?
Yeah, well, this is a reconstruction, but basically by the angiography, the acquisition, and also by artificial intelligence.
So it is AI.
It's AI.
AI, okay.
That feeds the system
so
as well.
everything is AI. This is going to be helpful.
That's going to be very helpful.
Okay.
So we can understand what's the significance there, and you can actually move the cursor, right? You can move the cursor throughout the segment to identify if you have significant stenosis or not.
So, and how was the result now?
The result is in the FFR. So you have a panoramic. So in the distal portion of the right coronary, you have 0.75.
Okay.
And if you see, it's almost like a pullback here, Fausto, because if you do go before when it's blue to the red, you see there's a, how can I say, jump. That's already on the stenosis area. So if you, I think if you go live, you can show it there because you can do the measurements on each segment. So that's how can I say, it's how much is significant this software and this technology.
So the FFR now, I would say, well, that's MiFR is 0.75.
It's 0.75.
Who makes this system?
So
there's no advertisement, so you can tell us.
Yeah, this system, it's a company based in China. Okay, so they're making this system in China already. There are like thousands of patients being treated every year. Multiple sites, hundreds of sites. This is coming to Brazil now. This is the first site in Latin America that we have performed this technology.
So how long does it take? You can have it in every cath lab. How long does it take to perform this?
So this is very important because before, in the previous versions of systems similar to that, you have to take the image from the cath lab and then transfer to a different computer and then do the measurement. That will take some minutes, and even the logistics will not be applied. So nowadays, everything is integrated. So this system that we have now is integrated, and we actually want to show, I mean, we already did this, but we want to show how easy this can be done on time. It's like take a few minutes. Okay. So it's a very, very
to make a decision.
Tool to make a decision.
Okay.
And one system is linked with all rooms.
Okay. One license and
one license you can have for the whole cath lab. Yes.
So, but you can do also after the exam too, if you want to go home. Study the patient, so you can do remotely.
Okay.
That's somebody.
That's a very good tool to identify the bad procedures.
Yes.
That are the ones.
Yes.
To the appropriateness.
Appropriate. I mean, bad, I mean appropriate.
Yeah. And the good thing is that only by angel. So we did the RCA.
Okay.
So we also went to the left main. And we did, the left system, we did the measure in the LED. You see here how the system recognizes from the left main up to the distal RCA, recognizes all the side branches. And this is the beauty of this system, because with AI, it keeps, becoming more refined and more consistent. So this analysis that was done here, and the result, Louis, was
88.
0.88. So there's not
So
significant
it's normal in the LED, in
Yeah.
the left system.
Yes.
from the left system, from the left main to the LED. And you can see it's only the green there in the function. You see some decrease, but not significant.
Yeah.
So that already tells us important information for decision making, that even though it's a culprit lesion in the LED, it does not cause
Ischemia.
significant ischemia.
Yes,
That's very important.
The good, if you notice, he take concepts on the left main, and you can do also only in the LED. So regardless if you have any trouble, there's some other leads on the left main, and I don't want to, how can I say, be in the part of the evaluation, you can do only the left main, you can do only in the LED.
Like you're doing a pullback of the wire.
Yes.
No invasive.
Yes, but no invasive.
No
You can do it
invasive.
at home.
Yes, that's great.
You can do it at home.
So Ricardo, what have you done?
So
So the decision is made. We don't need to treat the left main.
by ischemia, no.
How
But-
about if you want to see like another image,
yeah, but
for example,
many,
Ivals?
I think it's still debatable to some extent what to do with the culprit lesion. So we use here imaging as well. We did the angio. Can I have the angio, please?
Okay, let's take a look at the angel. Great.
Okay, so here you can see the left system. I would say less impressive, the left main, as compared to the previous angiogram. We like to do nitro before we do, but there's some mild disease in the distal left main, we can see here. And in the proximal LED is really a very mild disease, just a little bit above the diagonal branch, close to the first diagonal, actually. Here in the cranial, LAO cranial view, we see the same. There's a moderate disease in the distal portion.
It seems to me there is a tortuosity over close to the septal branch with the eccentric plaque.
Yeah, I'll call your attention here. I just try to get the right frame. You see that's a sign there of a ruptured plaque. It's a flap.
By angel, eh?
By angel.
Okay, great.
Yeah. So this is a sign of a culprit lesion, a ruptured plaque, but without significant compromise of the lumen.
Even the flow.
Between the two diagonal joints.
So we wanted to identify it and to have a more detailed information about this lesion.
So the plaque rupture that was the cause. It was so angel is so useful.
Yeah.
So you can see that by you. So Rodolfo, let me ask you Rodolfo again. So you have this by angel. You don't have eyeballs in the room, and you see that. Do you think we should treat this lesion?
No.
No, definitely not.
Definitely not.
That's another concept. Maybe just a few interventional cardiologists don't touch this lesion. They think, no, we are going to treat this and place a stent. So you are going to jail two large branches or three large branches, two diagonals, one septal, and maybe you can have problem. And this time you can just leave alone.
Yeah.
That's a Rodolfo opinion. Do you agree with Rodolfo?
I will say
And Ricardo,
And
so maybe you can investigate by eyeballs this.
Yeah, so we did the eyeballs.
Okay.
Get more
Can you have
detail,
the eyes just to show this, please?
And also, one interesting thing, when we have the guiding catheter close to the left main to the ostium, we could see the drop of the pressure.
Okay.
So it always calls our attention when we see this. So IVUS will be
We
helpful
need
for
to
this
check
as well.
the ostium.
Yes, yes.
Okay.
So can I have the IVUS, please?
Okay, great.
Okay, we starting, maybe just have the run and then we stop a few points. We started here in the mid LED. This is about 3.3 vessel. We already see some disease, some degree of calcification, but without compromise of the lumen. We're gonna see coming at about 10 and 4, the septal and the diagonal. And that's when you start to see the plaque. You see from 11 to 2. And you see the signs of the ruptured plaque there, but
Even in a calcified vessel,
a calcified vessel,
you have the rupture.
yeah, but no significant compromise of the lumen. And I think that's very important. Now we are approaching to the
So did you
proximal
measure
LED.
this lumen?
Yes, we're gonna show.
Uh-huh.
Well, we have the proximal LED, so there is a larger vessel.
Mm-hmm.
I would say here just mild disease. Now you see the circumflex coming at 9, and you can see the calcification from 3 to 5. And now you see the left main. It is a disease left main, no doubt about that. It should be a much larger as you compare to the proximal LED and the proximal circumflex, but with the lumen, I would say, preserved. Here, some eccentricity, some calcification. We approach here to the ostium.
There is some negative remodeling in the left
Maybe
main.
some negative remodeling. It's difficult because you cannot measure the other side,
Uh-huh.
but maybe could be. And here is the aorta coming.
Uh-huh.
So Wagner, can we go now frame by frame? So the distal vessel, as I mentioned, about 3.4, the diameter, lumen diameter. Next. Now that's where, just to correlate with the angio, that's where the septal and the second diagonal are. Next. Here, that's when you start to see the plaque, the calcified plaque from 10 to 1. Next. And here you see the minimum lumen area about 5.3, so much more than that number of 4 millimeters square. Next. Here, 5.2, another measure, 67% plaque burden around
And
that.
how about this image that you can see just close to the yellow?
Next,
It's
I'm
not
just
the
going to
plaque.
show the next one. Next. And you see
Are
here,
you not overestimating the area, the lumen
yeah,
area?
this is a beautiful image. You see the ruptured plaque there. You see a crater in the plaque. That's like a bite in the plaque. So you can see like exactly where we see that flap by angio between 12 and 3 o'clock. So this plaque was definitely the one that caused the acute event.
Okay, that's a great demonstration.
You just had a question before. Which one?
I was talking about the lumen area. I thought you measured,
Estimated.
you overestimate the area in that 5.2.
Back.
If you
Yeah,
look,
that's
I think
next
before
one.
this, 5.2.
Yeah, we had a small branch coming there. That's where you see some flow.
Okay.
There. So next, Wagner. Next. Próximo.
Sequência.
Próximo.
The left main here.
Vai seguindo, Wagner. Não, Wagner, as imagens estáticas. Pro final. À direita. Okay. So here we are. Próxima, Wagner, à direita. Próxima, continua. Okay, here we are at the left main. Wagner, as últimas à direita, as últimas. Isso.
Anterior,
Wagner. Isso.
Na DA.
At the left main, 5.7 millimeters square. E a próxima, Wagner? And 5.6 millimeters square. So, Fausto, here we have a disease left main. There's a eccentric plaque. The area is about 5.6, 5.7. We know that magic number, 6 millimeter square, below
But there is no ischemia.
You should treat. Above that, it's okay. But as we like to discuss here in our service, we don't treat numbers. We don't treat exams. We treat patients. So if you look at the data, it appears to be a stable plaque. This is not a culprit lesion. And we have seen data between 5, between 6. That's not it's still a gray zone. You don't have to just treat because you saw the number.
So that's a clear demonstration, Ricardo, if you agree with this, what I'm going to say, and that the rupture occurred in a non-severe plaque. No, so you have a severe lesion, maybe in the right, that we did not see any rupture, at least by now. But in the left system, in the LAD, we had like a mild plaque with a good lumen area and with a rupture.
Yeah, but without significant ischemia, because we did the MIFR as well, 0.88. So we did not find putting all together criteria.
Would you do anything different if you look at this artery in the first week after the acute event? It would change your mind or not? Just for the people who are watching us. Let's suppose the patient had an MI on Monday. He came to Dante on Friday, so 5 days later, and we saw this image. Should we treat or not? Because ischemia is not, appropriate to measure.
I will not use physiology. in regard to treat or not to treat, I think we can apply the same
Okay.
concepts that we have here
Okay.
today.
Do you agree, Rodolfo, with this? The same
Totally.
apply?
Yes.
Same apply. Okay. So what are you gonna do now?
Okay. So I would suggest that Luis shows now the MIFR, how we
Okay.
can do this easily
Okay, good.
on time.
And
And-
how you do this?
Yes, and we
Good.
want to go ahead and prepare to treat the RCA.
Can you have the
Rodolfo
camera on the
can
computer
check the
there?
guiding catheter.
And you can show the computer on.
Can
on
we
screen.
show now the computer, the MIFR, please?
It's the FFR.
The FFR.
FFR on the screen. Okay.
No, FFR.
No,
not the angel. Not the angel.
He's bringing.
The invasive.
Tudo bem aí?
Okay.
Yeah, thank you.
Okay,
Thank you.
good.
O cateter, tá?
So Fausto, I'm here. So you can see all the angels here that was done in this previous demonstration.
If you wanna change the camera here, I'm here. Okay, let's see. Okay, if you can follow me with this camera, it's gonna show Louis here where the computer is, just to show everyone. Good. Now I'm moving.
Solta o guia.
I'm moving. Follow me. Yes, great. And Louis is just here beside me.
Yeah. Okay.
Yeah.
Oh.
Yeah, good.
Okay.
You're gonna show there. Okay, great.
So Fausto, how can I say you can choose what the angel. You can choose what projection that we made. You can.
So Fausto, this computer is inside the cath lab.
Inside
It's
the-
integrated
Uh-huh.
with the system.
Uh-huh.
So once you acquire the angel, you already have the images in the computer, and you can
Okay.
select the images. That's what Luis is doing
Okay.
right now.
Let's see.
So okay. So let's do the RCA. So you choose the RCA.
Uh-huh.
Recognizes RCA. So
And you should try to get one view without overlap, and you see the vessel more straight,
Uh-huh.
end of diastole, without overlapping of branches. So you can really focus in the target lesion or the target segment. So that's what Luis is doing right now.
yeah, so he recognized the vessel here, Fausto.
Uh-huh.
And you can choose the frame that you wanna you can do the measurements. So
Yeah.
you can choose
So this is like doing a good optimal QCA at first,
Uh-huh.
selecting the right frame.
Okay.
so
with
let's see.
optimal.
Yeah, so as a key frame, okay, confirm is doing the computing,
Uh-huh.
and we can do how can
So
I,
you just stop here. So you see, folks, how good is this vessel contour detection?
Oh, yes.
It's very, very consistent, very consistent.
Everything was automatically.
Yes, everything. You just have to select the segments, the proximal and the distal
Uh,
points, and then you
They will
already
do
have
that.
automated
Yes.
selection.
So the
automated
red
detection.
and the blue.
Exactly.
Okay.
And this automated detection
Uh-huh.
already recognizes
Uh-huh.
the trace of the vessel. So Luis here, if you have to edit something, you can do it. But my experience with the system
Uh-huh.
is minimal, not to say you don't.
Uh-huh. Now
You
he's
have to do it.
okay.
so I'm just doing the contour of the vessel here, Fausto.
Okay.
Yeah.
That the machine did automatic, but I'm just correcting something
Okay.
here, so just to be
Yeah.
how can it be more
Okay.
precise.
Yeah.
No? So once we did, and it will be how can I say
Yeah.
correct?
Uh-huh.
I'll go to next, and he will do the measurement. So it's automatic. So
Now
now
the measure is gonna come
It's
now.
processing.
yes,
Processing. Okay. So this is AI.
This is
Yes.
is
AI.
by AI.
AI.
This is
By
feed
AI.
Yes.
Like you do in the angel in the
So that's not false.
And that's not. You see, this is like less than 2 minutes.
okay, yes.
You-
So this is 0.73.
0.73
yeah. So
distal vessel.
if you
Yes.
follow me here, Fausto, you can choose the point.
You can navigate.
Yeah.
Okay.
So that's the
Throughout the
pullback
vessel.
they were saying. You can see the numbers.
It's
here.
incredible. Yes.
Oh, it's 111
Yep.
999.
Oh,
So that's
that's absolutely
That's a
great.
drop. Yeah.
Yes. Yes, it's quick.
And you know,
Could you go back, please, a little
Yeah.
bit, just distal to the lesion, just to show everybody. Okay, stop at this point. So this is a 75.
Yes.
yes, yes.
Okay.
And if
Can you go proximal, please?
Yes.
Just
Yeah.
to see that proximal lesion. Oh, yes.
Yeah.
This is normal. Normal. Go down a little bit now.
Yeah, yeah.
Go down. Stop at the lesion, please. Yes, right there. A little bit
A
more.
little bit more. A little bit more.
A little more.
Yeah,
Okay,
yeah,
okay.
yeah.
You are at the lesion now.
Yeah.
So distal to this lesion. Can you go down a little bit, please?
Yeah.
That's where
Okay.
you see the
Yes.
drop.
Yeah. You start seeing the ischemia.
Yeah.
Yeah.
I mean, That's an absolutely great
And
demonstration.
here you see in already orange and red
Yeah.
distal. It means that all that segment from this point.
So it becomes red.
Yes.
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 It's a great
So-
demonstration, guys.
And
Like-
the thing,
So it's going to be the end of the guide wire measure. Ricardo,
I think this can
so
be-
there is a correlation. There's studies on
That's a very, very good correlation. That's
Please
many
come.
studies done already. And this is performed also by the Pulse Medical
Okay.
from China,
okay. Now the
And
camera
it's-
can come back to the operators, please.
and is distributed by Microport in Brazil.
Uh-huh.
And we think this in cath labs, as you mentioned, can make procedures much more appropriate in terms of indication and accuracy
Okay.
to really treat those causing ischemia.
Okay. That's absolutely great. So it's going to be part of the diagnosed
Part
Exactly.
diagnostic procedure. Exactly. Yeah.
the routine.
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 For the routine.
And you can create reports and you can
Yeah.
include this in the
So-
results of your exam.
So what are your plans now? It's to treat the RCA?
Yeah, so now we planning to go with the RCA. So here Rodolfo is advancing the wire.
Okay.
And since you already
Can you bring the angel in the screen, please, now? Okay, thank you.
Yes, me?
Now Rodolfo is working there. Rodolfo and Ricardo. So you have the wire or the guiding catheter. It's a JR4. You're using the radio.
It's a radio approach here.
Okay,
folks.
radio approach. How can you take the
Just-
IVOS out, please?
So
IVOS
this
image
is
out.
the angel we just did.
Okay, thank you.
You see the lesion here in the mid portion of this RCA.
Okay,
In this view, about 60%,
Yeah.
yeah,
but it's a centric lesion.
yeah,
In
It's more-
RAO
it's
view,
more severe.
More severe.
yes.
Here's where
I totally agree.
Yeah.
Yeah.
Here's where we did the MIFR. And we also did another one that looks even worse here.
So it's a large vessel
Very,
distal.
very centric lesion,
Yeah.
as Rodolfo mentioned.
So did you cross with the guide wire?
Yeah. So
Yes, we are just about to cross here, Faust. I think you're
So you're trying to cross with the guide wire. Are you going to use the guide wire tip to measure the estimation of the
Yes.
stent?
stent length here.
Yeah,
Faust.
stent length.
Yes.
Okay, we usually do this. Can you do again, Ricardo? Record this, please. Okay. Okay, great.
yeah. So we know what's the
How long is the wire tip?
It's 30,
30 millimeters.
yeah,
30
30
meters,
meters.
So, can you show? Okay. Can you record, please?
Yeah.
Okay,
Good,
good.
Faust.
Ricardo, can you explain us what the stent length you are going to use?
Yeah, so here is 30 millimeters. I think 30
Okay, yeah,
millimeters
zone,
fits
yeah,
very
that's
well
about-
because we have good landing zones by Angel.
Uh-huh.
And of course, we have IVOS here we can use to control the results, but I think we do have some mild disease in the proximal segment that
Okay.
we don't intend to treat.
Okay, good.
So maybe a 3.5 by 30.
So we cannot forget there is a severe dysfunction in the anterior wall, and we're going to treat the contralateral. So we need to pay attention
Yes.
in the huge right. You cannot have complications in
Yes,
this procedure.
absolutely.
So even a slow flow or
Yeah.
everything. So we need to
Yeah.
do concentrating on this now
Very important.
because the anterior wall is
Very important. So Rodolfo is advancing the wire here distal when we see the stents.
so you're going to do a direct stent implantation or predilation?
I think predilation here.
Also,
Yes.
one trick. We are using a non-polymeric wire.
Non-polymeric
And I
wire.
have some difficult to dip the wire because
Okay.
the tortuosity and the calcium.
Cross
the viscosity.
classification. Okay.
We will go with a balloon in the proximal segment and
Huh?
go.
Okay. May you have the with the operators, please? The camera
Okay.
with the operators. No hemodynamics right now. And okay, thank you. So we are going to use the balloon to get a better support of the wire.
Yes, I think.
Atrito, como fala atrito? Para não ter
Ok.
mais atrito, né? Para tirar o atrito.
Yes,
Okay, so he's advancing the balloon just to put in the mid portion, then he could advance more the wire,
Okay.
become more stable. You see the support there is not optimal with
Mhm.
this guiding catheter.
Okay.
So If you have the wire very distal, maybe that's not a problem, but if not, maybe to change for AL1 with a better support could be a good idea too. Well, let's see how it goes. Vamos trocar, Rodolfo. Vai. Pega AL1, por favor. Terapêutico.
Do you think you need to change the guiding catheter, Rodolfo?
Perhaps we can do some anchor here, Fausto. if
Okay.
need.
Okay, so now
Good,
better.
good, you got it.
Now
No.
better. Okay.
All right.
So just 1, 2.
Plate
So what size of this balloon?
It's 3
3
flow by
By-
20.
By 20. So you're pre-dilating the lesion. Now
mais.
it's a calcified vessel.
Pode 20.
Now the predilation.
Ok. Plate.
Ricardo, you can say something
Plate?
if you need.
Yeah. So
If you want.
dilating here, preparing the lesion, that's some
para trás.
perclosity proximal. So I think that's a good idea.
Okay.
That's how we do in our practice. You can also use this to engage better your guiding catheter.
Mhm.
And you see how the wire now goes very deep in
Pode 20.
because of this technique.
Ok.
So now you're much safer to advance a stent here.
Great.
And if you
What size the stent you're going to use, Rodolfo? 3.5 by 30? Stent size.
Stent.
so
Fausto, the land zone it's
There is-
something that concerns here.
3.5
3.5 but
proximal.
By the low pressure,
if you want to cover the
there is some
proximal lesion,
it is proximal.
Mhm.
If you accept the
I think
don't
it's okay
touch
not to
in
treat,
this
yeah.
proximal lesion, okay, the land zone is just
maybe
just
28,
depend.
real by 28.
28.
3,5 por 28, por favor.
Okay.
Ou 29.
3.5 by 28 was the decision here.
28, 29 ou 30.
And
3,5.
you are going to see the position. And you are going to check the results with IVOS that
Okay.
you have on the
Just
table.
open here.
And also with the MIFAR. MIFAR?
Yes. You
MIFAR.
can do it. That's a very good thing to control your procedure,
Mhm.
to do at the end of procedure as well.
Okay, let's
So
see.
you know the result pre and you know the result after.
Okay, we're going to see that.
Yeah.
Great.
And here
We still have 20 minutes, 25
here
minutes to go.
we intend not to treat the proximal lesion,
Okay.
which is a mild lesion. We don't really believe that longer stents are better. We have
Okay.
just to treat what you think it's important and significant.
Okay, let's see. So what kind of stent you are going to use at this time?
So we're using here is Inspire stent.
Inspire stent,
Inspire stent.
the Brazilian stent.
This is the Brazilian made stent.
Yeah.
So it's a low profile, about 70 microns. It's a PLA based biodegradable polymer.
What's
with
the
sirolimus, low dose. This stent has been developed in our country, and there's some studies that we also participate in the institution. They have demonstrated to be to have all the features of what you expect for a new DS with excellent performance.
You have the box of the Inspire just to show them here. Just please, this is the Inspire stamp. Can you show the camera there?
You have the camera here?
Yeah. Just to show the stamp. This is I mean, it's not advertised, but it's a Brazilian stamp.
Yeah.
Yeah. Right here.
And I would say results very comparable to
Come here with this. Okay. Yeah.
to those used
Inspire on.
in clinical practice.
That inspire us. That's a good word. When you have some inspiration, it's good.
Yeah.
When I'm here in the 360, I get inspired too, and we can teach and we can share everything that we do here to help the health of
So
patients.
also they just advanced the stent.
Mhm.
The stent,
Yep. Let's see. Thank you.
This stent navigates very easily
Mhm.
in more complex anatomy because a very low profile. That's a good thing. So now they're going to deploy it.
Okay.
I think they're good landing zones. There's some dissection distal due to the predilatation,
Uh-huh.
but I think that's a good position.
Aí, chega.
And
Nossa.
we like to do like in the nominal pressure, but don't
Okay.
overexpand and just
You went up to
post-dilate.
8 atmosphere,
7.
7 atmosphere.
It's just where it opens.
Uh-huh.
So that's enough, and you don't cause edge injuries, and you can just post that.
Okay, great.
Post 3,520, por favor.
So you're going to postdilate with a 3.5 by
5
20.
by 20, yes.
Oh,
And then we do
pegar o
the
descente
control IVUS.
So if you want
Yes.
to measure the MFR now, you can do that.
We can do that. Because the images,
I
they
guess so.
already capture in the
In the-
computer,
Okay.
in the program software.
So
which
the image is over there in
is
the
already
computer.
over there, yes.
So Daniel, it can do that now.
Yeah, it's integrated with the cath lab imaging acquisition.
Let me ask him.
Você quer ir lá, Luiz, para fazer análise?
ok.
Vai lá.
You have
Vamos
a última imagem.
É,
2018.
Essa última.
desceu, não desceu ainda.
Yeah. Mede, vamos ver.
Quando insuflou para
Uhum.
baixo. Ó.
A gente vê isso aqui.
Você tem que completar, aproximar.
Uhum.
Não pode latar mesmo?
Aqui, ó. Acho que
Vamos lá? Balão de posse?
Acho que é aquele 3 mesmo, 320. Ou 320
O de posse?
que a gente estava aí. O mesmo. Esse aqui, ó.
Pega um
Esse aqui,
325,
ó.
então,
Aqui, ó.
balão de posse, 325, 20, por favor.
Podia o outro assistente ali já.
Deixa assim. Alguma coisa proximal.
Não, está ok. So now we
Good.
moving here to do balloon pulse dilatation.
É angiografia, não é?
Additional stent to the proximal
Mais?
artery or not?
I think so.
Okay.
Spiral, 3,5.
Yes.
So the stent falls, I think is perfect. I think it's nice. I think it's well positioned, good landing zone. Now the question, there's this disease proximal. Biangial, before we started, it was not significant. But once you put a stent, sometimes you're more likely to try to get a result throughout the segment. I think that's a decision to be made. There's no right and wrong here. Maybe some accordion effect.
Yes, I would say that accordion
Yeah,
effect.
accordion effect. I think that's a little
I
bit
was
there.
missing this word.
Spasm, yeah. We can do
Nitro?
some nitro here, and then
Nitro
even use
and
IVUS to make a
Yes.
decision.
You can do
Nitro
imaging.
and IVUS.
Yeah, we're gonna do the IVUS, and then I think we can decide.
Okay. And while we are preparing this, maybe you can just measure
Okay.
the MFR.
Yeah.
Okay.
So
Can you
do- you can do the
you have the MFR, the computer, I mean the FFR and
Can
the
we just do the
screen, please?
acquisition here, Luis, so you can do your evaluation?
May you have the screen, the FFR and the screen now? Yes.
Okay, so that's a good one for you to do the analysis,
Yes.
Luis.
We are going to do another analysis and a physiological analysis now. And how you are working on this? This is the physiological,
Deixa em
Yes,
3,5.
or this is the hemodynamic?
Não, 28.
You have the computer,
Sim.
the FFR on the screen, please? And could be in the big
FFR,
screen.
please, FFR.
Yes,
Okay,
FFR. May you have in the big screen now, please?
MFR in the big screen, please.
Yes, perfect. Thank you.
Great.
So now we just did the acquisition in the last injection,
yes.
and Louis now is preparing and
Não,
taking care of this.
29.
Now you're going to see
Deixa eu-
how long does it take. I'm going to measure now. It's 12:41, 18 seconds. Let's see when you have everything ready. Now that it was
Pedro,
treated,
ajuda aqui, por favor.
you can see the
Yes, I'm doing
the red and the blue. Now we have about 15 seconds. You have worked on this. And the computer is working just to see the measurement, the FFR.
0.9 side here.
Now, so you have like 30 seconds. It's ready.
Yes, 0.97.
So it's a 0.97
Yes.
distal now.
Yeah,
If you-
he's saying now what brings to the computer is the most severe lesion. It will be the distal one.
Distal one. Okay.
Enche o
The mid
peito.
portion of the
Okay.
RCA.
Can you bring a little bit proximal, just
Yes.
distal to the stent, please?
Yes, here.
Okay. Yes. So this is stent segment. Go
Yes.
distal, please. Go down. Go down or go down. Okay. Stop, please. So 0.99.
Yes.
That's perfect. There is no ischemia at this point after you treat the lesion.
Yes,
So you
yes.
did that in 30 seconds, the FFR post-stent implantation.
So,
Now they are going to make a decision if you have some
Consider
anatomic
normal.
yeah.
features.
But by this result, you don't need to treat because it causes ischemia.
Yeah.
Only if you feel like it's injured, right?
So yeah, injured in
Yeah.
the proximal part of the
Yeah.
art. So you're going to do IVUS now?
We're going to do IVUS.
Okay,
Is
let's
that good?
let's see the IVUS image.
But this is just amazing how you can control the result of your
Enche
procedure
o peito bem
in
Immediate-
time.
On time.
Yeah,
That's a-
immediately in the cath lab.
That was a great demonstration, Ricardo,
Yeah.
because we could see here exactly how you were seeing the screen,
How it was
the
before.
physiological.
Yeah,
Now let's see the IVUS
Pode
image.
respirar.
yeah.
That's a show.
Respira normal.
That's great. That's great. Let's see.
So we have here. Deixa que eu faço.
The IVUS image now, we are going to take a look.
So we are distal to the RCA. We're going to start the pullback here. We are distal to the stent. The RCA, very large vessel, it's close to pleural vessel. Lumen is about 3/4, 3/5. We can see here distal some plaque disease, some, let's say, mild to moderate compromise, some calcification between 12. Now this is the distal transition of the stent. Clearly, some part of under expansion there. There needs to maybe have a stent, larger stent. We just saw here the dissection behind the struts that was caused by the predilatation. Here we are in the mid portion of the stent. Is I would say larger
Ficou faltando um pouquinho.
vessel here.
O 3,25 está maior do que o 3,5.
As we come to the proximal segment,
Onde ela está com 3,25.
I think
E
there's
aqui mesmo
room
maior
for
do que o lente.
optimization
pouco
here
mais
of
distal.
the expansion. So Rodolfo makes a 3.5 balloon could be a good idea, just to fit better to the vessel size. here a little bit under expansions because of the calcification, more elliptical form. But overall, the area it's very acceptable, very good. That's not a problem. Here we just saw proximal dissection of the vessel. So yes, I think you should consider to have a stent in the proximal part, proximal edge. Here we are in that portion of the vessel that has some mild disease, some irregularities. And we see a big plaque burden at this point.
So Ricardo, can you summarize the IVUS finding, please?
Yes.
Please come. Can you have the camera and the operators now, please?
The culprit lesion has been well treated in terms of the segment, the length.
May you have the angel, please, on the screen now?
There is room for optimization of the expansion because the vessel is really large. And maybe a 3-5 balloon, I think will be okay. There's some spots in the very distal end and the proximal that has some degree of under expansion. More important, in the proximal segment, there's some proximal dissection and a very more significant plaque burden and disease. So I think it makes sense to put another stent.
Okay.
I think that's a good idea.
So you are going to cover that proximal dissection, Rodolfo, for another stent?
Yeah.
Okay.
3-5.
Another
12.
29?
12.
33?
Segmento inteiro?
Oh,
Yes, the measurement from the
just
IVUS, I think there's a 14 segment.
Só lesão pequena.
So I'm just going to measure here what would be the length here.
Vou cobrir só de secção é 12. Vou cobrir tudo.
May you have the camera with the IVUS now? IVUS measure, please. IVUS on the screen, please.
Quer cobrir tudo? Precisa? Quer cobrir tudo?
Sim.
Tudo? Então é 29. É o grande, 29.
So
the
23, 24.
yeah, I'm just bringing here.
23?
So about
3.5 by
24,
23?
24. So 28, you can have some overlap. 28, 29. I think it's okay.
Okay, 29.
3.5.
23, 35, 20.
Ou 26 tem 26.
How about 23? 23 it's going to be enough, no? Or not? No?
Vai
ter watch.
overlap just. Vai fazer overlap no ramo.
23, I think
Pode ser
it's going to be
3,25.
very.
3,
Tem 26, 3,5, 26, por favor.
3,20.
3.5 by 26.
Pode ser 25 aí o 3,25, 3,5.
And
Por Ciro. Pode ser 3, a gente pode ir lá.
there is this
3,25.
326.
evidence even
Okay.
from the tulip study already that long lesions are the one that could benefit from IVUS guidance. And it's a good idea to guide the procedure here. And RCA can always be challenging. So we're going here with this stent.
So may you have the angel now on the screen, please? They are going to work and they're going to place a proximal stent and where we got that small dissection. But without
Because the stent moved down.
yeah, okay.
So it's important to say that we are not treating here because it's a mild lesion.
Okay,
it's
so-
because there's injury, acute injury.
So why do you think the stent went down, Ricardo?
RCA, when the patient takes a deep breath, sometimes you can have this
okay.
problem.
Yeah.
And because this patient is under sedation, you cannot control that.
Okay.
Sometimes it's better to have the patient
So
awake.
okay.
So he doesn't do that.
Enche o peito fundo, segura. Respira fundo agora.
So we're trying here to do some maneuvers here to sort this out.
There is some calcium.
Yeah.
Próximo.
So we deepen here, intubating here, the guiding catheter.
Okay.
So
Good.
that's enough.
Pode respirar normal.
And now just to find the minimum overlap and
Teste,
go
teste,
to the
Luiz,
awesome.
teste.
Teste, Luiz, por favor.
Now you have another stent at
25.
3.5
Pouquinho pra
So
trás.
I think it just
Testinho.
and cover all the
goes-
that
yes,
segment.
Yes.
Teste.
So you have time to
Ok, vai.
deploy the stent,
Right.
do the post dilation,
And then do another.
and
IVUS.
finish with the IVUS image. We
Okay.
still have 10 minutes to go.
Is it,
Pode ir. Vai 20. 20?
So you deployed at 8 atmosphere or
25?
10?
No, no.
It's a 3-0.
It's at you.
3.0.
3-0.
We don't have, okay.
So you post dilate with a 3.5?
Yes.
3.5.
3.5 by 20. Do you have on the table or not?
Yes, we're
13
going to
meter
ask.
20.
Yes.
Tá bom.
Yeah. So,
Okay.
Okay, so just a control angel, everything's fine. We're gonna post dilate.
so
and
you
then
need
do
to
the
work
control
on
angel.
in all
5, 20.
segment of
all the
this.
segments for post dilatation.
Stent segments.
Exactly.
So the blood pressure is okay. If you want to show the hemodynamics, please.
Blood pressure is fine, and as you mentioned, Fausto, it's a special care here
Tira aqui.
to not
Já tá limpo.
use much contrast because this patient has significant
LV
LV
dysfunction.
And imaging is helpful as well.
Oh, yes.
Invasive imaging is helpful for that.
Great. Good point. Lixo.
3,5. Posso soltar? So we're advancing here now, 3.5 by 20.
So after this, we're going to have the IVUS
We're
read
gonna do the
to
IVUS.
check with the IVUS. Okay.
Yeah.
It's going to be a long run
Yeah.
for
And also, we are starting here a protocol in our institution to use the MIFR in the routine practice.
okay.
So the patient comes to diagnostic cath and we can use on time. When they get the report, we already have the information
Oh.
about the physiology.
Great.
So this
Absolutely great.
is going to save
Dois.
a lot for
Yes.
decision making.
For the public system. Also.
Yes, yes,
So you don't need to have another ischemia test.
exactly.
Right.
Unfortunately, a lot of these patients, they
So the residents,
don't come.
the fellows, they are going to have more work to do now.
Yeah.
But it's so fast.
Yeah,
I saw here, it took like 35 seconds.
35 seconds. And you can do in all the vessels, you can do in all the segments.
Yeah.
Really, you have no doubt what are the,
This is
the significance.
disrupture.
This is rupture.
Disrupt.
Yes.
Great.
And I think in a few years, you're going to see this in a season like this in most of the cath labs
Okay.
with AI. So here we're optimizing the post-dilatation. It's very important to do
So
this.
you ran up to 25, 26 atmosphere,
26.
Louis?
26.
26.
Here.
And we're getting ready here for another IVUS run.
Mhm.
Do the
And I
angel
think
here.
Three. 14.
Perfect.
Okay.
we can demonstrate now.
Can you record this?
Just record it.
Can you measure the MFR there
Can you
with
do
this?
the MFR again?
Yeah, sure.
Do you think so?
Yeah.
Okay.
Let me do here.
Let's measure with the last image. Do you have the last acquisition
And
here?
who's going to
The last acquisition.
do the measure as we advance here to do a IVUS control.
Yeah.
Very
Okay.
important when you do IVUS guided procedure.
And while Ricardo is preparing the IVUS guide, let's go to the FFR image now, please.
that you
Louis is measuring the FFR. Can you do that, please? The FFR image from the computer. Okay, great. Louis is using the last acquisition they did there. He's measuring again after the second stent. Just to take a look how it looks like.
Você tá pisando? Eu acho
Não.
que tem uma.
Now the computing, as you can see here.
Yeah, just to remind here, Faust, that
Great.
because of the guide wire here,
Yes.
you have some, how can I
Okay.
say?
Can you go a little bit proximal to this and just to show? Okay,
Here's-
okay.
Yes, here.
So it's
But here
97,
it's-
90. Okay.
yes.
Then in this point, we have the guide wire or some spasm or something like this.
I think the guide wire is a vessel.
Okay. Oh, okay. And now you have a normal FFR in the whole segment.
Yes,
So it's 0.97. Is that correct?
yes, 0.97, yes.
Okay. Can you correct this where the guide wire is or not?
Yes, I can.
Just to to confirm this. And when Ricardo, do you have the image?
We do
Okay,
have the
can you
image.
go to the IVUS
We
image
just
now?
started.
Can
Yeah,
you show this later, please?
just started.
IVUS, okay.
So just started is much better. That underexpanded spot at the distal portion now is solved. You see much better fit to the lumen size. The vessel size even larger, but you like to apply here according to the lumen diameter, reference lumen diameter. We're coming close to the overlapping segment. Throughout the entire segment, we see a uniform expansion, a much and adequately sized stent area to the vessel size. Here's where we're gonna see the overlap. We just saw the overlapping. Rodolfo just removed the guiding catheter from the ostium, which we should always do that. Here, due to the calcification, there's some eccentricity, but the area, it's really well preserved. We're coming now to the proximal segment. The proximal stent has been deployed. That's where we have the significant dissection there. There's a huge plaque burden here at this point. You see the vessel maybe like 6, but a lot of plaque burden. You see the lumen, it's very uniform to what we have seen throughout the vessel. We're coming close to the ostium. Okay, here. We're just by the ostium.
Okay.
It's just perfect position.
Perfect in the ocean.
One strut out.
Okay,
That's how you want to do it. So I think we're very satisfied, Fausto,
okay.
with the result here by IVUS, and we can do a final angio acquisition. Maybe we can
Yes.
do.
We have this,
The
the
final-
engine on the screen now, after this beautiful IVUS run.
Did you? We're gonna do nitro, and then we're gonna do a final angio.
So you have 3 minutes to go. We're gonna show the final angel without the wire inside, and we try to measure the MFR, MFR. I need to learn how to say this
Yeah,
Chinese word.
MFR.
MFR.
Yeah,
Okay,
me as the Latin letter. Yeah,
Latin. Ah, it's Latin.
yeah.
Okay,
Greek.
okay.
Pode filmar.
Let's see.
So
We're
here we are
doing
in the
the
LAO
acquisition.
control.
Great.
It's beautiful result.
That's a beautiful result in
What
this
you see here, some
huge right coronary
huge
artery.
right dissection behind the struts, because that's normal. That's gonna
Uh-huh.
heal. But huge vessel, very uniform, very good
Okay.
result by IVUS.
So
We are very happy with this result.
okay, can you move the image now? Okay, Rodolfo is gonna do the last one here. You can show this. Great. Normal
So-
distal flow. And now, can you bring the computer image from the FFR, please, in the screen? And Louis is measuring there. Okay. The FFR computer
So
image.
Here, Fausto.
Okay, you have.
0.99.
Okay,
0.99.
okay.
Before the
Ricardo is so
trial,
anxious just to show it's 0.99. So since the beginning, you see, this is the stent segment. You're gonna go distal now. Distal, where we have the wire tortuous at that time. So it's a distal vessel is 0.99. So this was a great demonstration, guys. It's perfect. So may you have the image now for the operators in the large screen? Okay, thank you. So with this beautiful demonstration from a patient with the ACS, that's very common in our hospital, that come from a primary hospital where they were undergoing two lytics. This patient had an MI, came with ACS. The culprit lesion was an LAD that was not severe and was not treated because of the physiology and the IVUS image. But the non-culprit lesion was in the right, in the huge right, that was treated with the 2 coronary stents. And we could show the MFR. So I thank you so much, Rodolfo, Ricardo Costa, Luis Nakayama, and also Pedro Teixeira, and all the nurses here, the anesthesiologist. Who is the anesthesiologist today? Renato. and Wagner, and also the people from Microport, from the Chinese company that support us with these beautiful images and measuring a non-invasive coronary flow reserve.
Yes.
Okay. Thank you.
Great.
Thank you,
Thank
Medvedev.
you.
Thank
I'll
you.
see you next week.
See you.
Bye.
Bye.
Espetáculo. Você viu que demonstração?
Demonstração bacana.
Bacana esse inédito. Isso é inteligência artificial. Olha o que eles mostraram lá.